Okay, let's get started. My pleasure to introduce our speaker today, Dr. Robert McGee. Dr. McGee is an associate professor of cardiothoracic surgery here at CU, and Dr. McGee joined the faculty in 2012 after he completed his residency in general surgery at Johns Hopkins, and after completing a CT fellowship at the University of Washington. And Dr. McGee is the director of the Surgical Outcomes and Applied Research Program, and his main interest is in identification and development of processes and systems of care that ultimately will lead to improved outcomes in surgical patients. And that's what he's talking today, and I'm very excited to have him here. Thank you so much, Bob.
Morning, everyone. Thank you, Dr. Eccles and Dr. Todorovic, for inviting me to present. This morning, I'm going to talk about surgical risk assessment and my research from the past 7 years as a faculty member here. Can everyone hear me okay with this mic? Okay. This research has been supported by intramural and extramural funding. I don't have any disclosures. This is an update. I was doing a lung transplant yesterday morning with Ben Abrams, and he said, "Oh, didn't you give a talk a few years ago?" Yep, this is an update on that talk, where a few years ago I presented a project that we had in its infancy, and since then we've done a series of studies to try and take in the next set of directions. So the aims this morning are to understand the current state of surgical risk assessment, to understand what patients desire during the surgical consent process, and then to understand local options for surgical risk assessment and documentation. As a background, risk assessment is fundamental to the practice of medicine and surgery, and we all engage in risk assessment actively and passively in all aspects of our clinical care that we all deliver. There is a New York Supreme Court ruling from 1914 noting that informed consent is a legal, ethical, and practical requirement where Judge Cardozo stated that a surgeon who performs an operation without a patient's consent commits an assault. And then based on this, we think about the consent process as a transfer of information between the provider and the patient. And we know that patients rely on the consent process for this information about surgery and the procedures they're going to undergo. They use that to help them understand the possible risks, and that's a key component of consent. And over the past decade or so, there's been an uptake in shared decision-making, which has slowly crept from internal medicine through the other specialties over to surgery, where patients have become partners in their own care as opposed to patients being the subject of our care delivered to them. Some studies have commented that there's a big gap that exists between the theoretical and legal best practice and the daily practice of informed consent. An optimally informed patient will have more realistic expectations regarding a surgical procedure and its associated risks. Well-informed patients will be more satisfied and file fewer legal claims, so that's good. And the use of interactive computer-based programs provides an opportunity to improve surgical informed consent process. And then our own literature review has demonstrated that future development of surgical communication tools and techniques should emphasize on standardizing what risks are shared with patients. So opportunities exist in this space. We recently completed a survey of about 100 surgical faculty and residents, and we asked them a series of questions. One was on the use of an online risk calculator, and we found that the faculty representing the older, more experienced group of surgeons in the study, 58% of them never or rarely use surgical risk calculator tools, whereas a little more than half of the residents sometimes use them. We found when we asked surgeons, what do you rely on for making your decisions on surgical risk estimates, the senior part of the group, the faculty, again, 82% of them relied on their prior experience to estimate risk, most or all of the time, whereas only about a third of the residents relied on their prior experience. And obviously experience is something that grows with time and exposure. So surgical residents with less experience than faculty rely on adjuncts for risk assessment, and we see this as an opportunity to help train residents. The same survey, we asked about barriers preventing formal use of risk analytic tools, and we found that moderate or significant barriers included the amount of time needed to use the tool in 2/3 of the respondents, the inaccessibility of the tool during the patient clinic visit in just about 2/3 of the respondents, lack of integration of the tool into the electronic health record that we all spend so much time in front of, unfortunately, 2/3 of the time again, lack of trust in the tool's accuracy, just over half of the time, and then inability of patients to understand the results in just under half of the encounters. We asked the respondents about desired features of risk calculators, and the majority responded in automatic integration of the risk factors within the electronic health record and automatic recording of the results into the electronic health record to provide a response, to document the response. We also asked the surgical respondents, how do you communicate surgical risk to patients? And 50% of the faculty said they always or most of the time rely on the pre-procedure services clinic at UCH to communicate that risk. Are the members of pre-procedure services here this morning? Great. So in our conversation with you guys a couple of years ago, when you were using the surgical risk assessment tool that we're going to talk about today, you told us, look, we don't feel comfortable sharing the surgical risks. If Schulich sends us a patient who's getting a Whipple, why should we be talking about the patient's risk of a pancreatic duct leak after surgery when Schulich's the one doing the case? And I totally agree with you. So there's a disconnect between what the surgical faculty are thinking is going on versus what we expect is going on. So the problem is preoperative risk prediction is crude, and patients are poorly educated about their surgical risk. And the risk of its adverse surgical outcomes is an educated estimate based on past experience by surgeons. Sometimes they cite the literature. But unlike antibiotics use or chemotherapy, it's not formally individualized to the patient, despite being in an era of large volume data that we could use to estimate surgical outcomes reliably. There are some tools that exist. There's the VA Surgical Risk Calculator for those of you who've been at the VA. It's fraught with the typical challenges of the VA. It's only available on the VA's intranet. You have to put in 45 to 70 data points entered manually, including sodium, potassium, chloride, and just ridiculous data. It takes about 30 minutes to fill out. I used to have my residents fill it out before they came to the OR, and they were reliably 30 minutes late to the OR because they were filling this out. And at the end of the day, it only provides an estimate of 30-day mortality, which is not really what our patients are interested in, especially in the majority of the surgery we do, which is low risk. They're more interested in quality of life outcomes and complications and when are they going to go home. There's the STS Adult Cardiac Surgical Risk Calculator. That's based on the STS Cardiac Database, which has become the gold standard for data collection. It's available nationally, freely online. As a surgical cardiothoracic fellow, we used to have to enter this before surgery. You have to put in 50 to 60 data points per operation per patient. It estimates the mortality and 8 different complications for some cardiac procedures, so it's a lot better. It's closer to the mark of what we'd like. But this is what the output looks like. I tell the patient your risk of a short length of stay is 13.855%. I don't know what that means. I don't even know what they mean by short length of stay. So again, it's moving in the right direction but missing the mark when I think of what I'd like as a patient. The American College of Surgeons has developed the surgical risk calculator, again, freely available online based on the NSQIP database of 6 million patients in the U.S. It requires manual entry of 25 data points, including some lab values. It estimates 30-day mortality and 11 different complications, so it's much closer to something useful. And it does provide patient risk versus the national average. This is what the output looks like. Unfortunately, it's online. It's hard to share this with the patient. It's not in a patient-friendly output. So we believe that the problems with existing risk assessment tools are they're not routinely used by providers for a whole host of reasons. There's too many different specific models for clinicians to use. There's different models based on different patient populations and based on different types of disease or operations. They take too much time to use in the compressed clinic environment where we're all rushing to see patients in a brief amount of time. They require too much provider-entered data. Looking for labs in the chart is not reasonable, especially on outside patients who come to clinic who don't have their labs in our system. They don't provide enough useful information. They're not integrated into the electronic health record. And as a result, they don't get used. So our team initially took the approach of thinking, okay, what is necessary for a risk assessment tool to be accepted into widespread use? And this is about where we were when I presented to you 3 years ago. In order for a tool to be accepted, we think it must be quick and easy to use. So since we live in the Epic EHR on a daily basis, it should be integrated into that EHR, not separately available through the internet. It should provide reliable and meaningful estimates so we believe the output and can utilize that to change our decisions and our patients' care. It should be broadly encompassing of many different types of surgery and surgical complications, so you only have to go to one place for one tool. It should be based on readily available preoperative data, so I don't have to search the EHR to find what the patient's potassium was 10 weeks ago. It should be incorporated into the preoperative note so that there's a record that it happened and we can refer back to it. And it should be available to the public and updated periodically so it remains accurate and salient. So with this approach, we started tackling this development of a surgical risk tool. We started using the ACS NISQIP database, which is at the time and for the most part still is the gold standard in a broad surgical database. At the time, it was 2.3 million records from 2005 to 2012 from 600 different hospitals. We update our algorithms yearly. Currently, we're using 6 million records between 2008 and 2017 from 800 hospitals in the U.S. It encompasses 3,000 different CPT codes and 9 surgical specialties. It's built into our EHR, and I'll show you that in a minute. We use only preoperatively available data, so we're not relying on data that's made a call at the time of surgery or post hoc. We strove for parsimony of models and the variables in the models to make it easier to use, and we sought input from providers, surgeons, anesthesiologists, clinicians, patients, administrators here at the hospital, and our legal counsel as well to make sure we were not missing the mark and that we were addressing the issues that all the different parties thought were salient. The output resulted in 8 different models that predict 11 adverse outcomes across a broad range of surgical operations with a high degree of accuracy, discrimination, and calibration. This is applicable to 9 surgical specialties: general, vascular, ortho, thoracics, plastics, gynecologic surgery, urology, neurosurgery, and otolaryngology. And these are the variables in the table. The CPT-related risk, whether or not how complex the operation is. And in the model, this is replaced by some lookup tables using the CPT code or the procedure name. The patient's age, their functional health status, so are they functionally independent? Are they partially dependent on activities of daily living, or are they fully dependent on activities of daily living? The ASA class, which you all know and we all know well. Whether or not the patient's an inpatient or an outpatient operation, the surgeon's specialty from those 9 specialties, and whether or not the operation is an emergency operation. This gives 11 different 30-day outcomes: mortality, overall morbidity, unplanned readmission, infectious complications, whether or not the patient's going to at a high risk of a transfusion, pulmonary complications, so prolonged intubation, unplanned reintubation within 72 hours of surgery or pneumonia, UTI, venous thromboembolic events requiring anticoagulation, cardiac events, acute and chronic renal failure, and stroke. And then we've added recently the models for discharge destination, but it hasn't been built up into the online model yet, or the EHR model yet. And we used a technique called factor analysis to parse all these outcomes from the American College of Surgeons NISQIP database into more meaningful, clinically driven outcomes that are related to each other, as opposed to providing each of them individually or having an arbitrary distinction as what's a major complication versus a minor complication, because a UTI to someone who had an outpatient inguinal hernia is probably more of a major complication than a UTI after a lung resection, but that's a patient perception, not a clinician-driven decision. It's in it's in Epic. It's called Surpass. It's meant to be in every provider's Epic encounter in the UC Health system. If you use Control K, it should open up when you're in an active patient record. in my EHR, this is what it looks like. It's a chunky button in the left corner where I can click on it when I'm seeing a patient in clinic or an inpatient who needs surgery as an inpatient. When you open up the tool, this is what it looks like. You start by entering the procedure. There's a drop-down menu. You start typing the procedure. It searches for the procedure and uses a word matching algorithm. Once you've entered the procedure, it pre-populates the patient's age. You click on their functional health status, their ASA class, whether or not the patient will be an in or outpatient after surgery. Once you default the specialty, it stays with the defaulted specialty until you change it again, and whether or not the operation is an emergency. And as soon as you enter that, you're provided with a comparison for you as a provider showing the individual patient risk, which is those orange bars, and the average risk for the procedure out of that national database in the blue lines. And then you get a table showing the patient's risk versus the average risk. And the table flags where the patient's risk exceeds the average risk. There's documentation with a dot phrase or dot surpass that puts in the documentation of the risk assessment and what the risk estimates were compared to the national average. There's a handout that's generated that's a PDF that we print out in clinic, or I print out when I'm in the MICU seeing a patient who's been consulted on, that I can then go and talk to the patient and their family about. This was developed using focus groups with patients where we showed them 10 different ways of looking at risk and how they understood it. And the vast majority selected this little stick figure model. And the patients also told us they wanted to see their national average. We hadn't actually thought of that, but they wanted to see the national average as a comparison so they could see if they're higher or lower than the national average, because as a human race, I guess we're competitive in that respect. And it's amazing when I use this in clinic and hand this to the patient, the conversation about risk takes me about 3 minutes instead of sort of bumbling through it in 5 to 10 minutes. The answers the patients come up with are much more in-depth than I'd ever anticipated. The patients look at this, they take it home with them. We asked patients in a series of interviews, what's useful about this? They say, well, when you talk to me, doc, I'm thinking about the fact you just told me I have lung cancer. Now you then talk to me about the operation and then the plans, and it's overwhelming. When I go home, my wife says, what did you talk about? I can say, well, the doc gave me this. We talked about the risk. This is how I stand. This is the national average. And so we've been impressed by the response by the patients. We've done a series of studies to try and determine if we're on the mark or missing the mark. We started by looking at the Surpass tool that's in Epic and just here that we developed compared to the ACS's surgical risk calculator, which is freely available online. There's only one publication on the ACS risk calculator on its development. You read it, it doesn't describe much, doesn't give you much detail. None of the algorithms are made available. You can't reproduce it in your own institution. So we had one of the surgical residents go online and enter 1,000 patients, standard patients we pulled from NSQIP where we knew their outcomes into the risk calculator. It took him about 3 months, and he entered each one and recorded the outcomes. And then we ran that through our risk model. It took about 30 seconds. We compared the outcomes, and we found that the mortality estimates were similar for those 1,000 patients. When we looked at the risk estimate for overall morbidity by the risk calculator from the American College of Surgeons, we found it underestimated the morbidity as the patient's morbidity increased. So on this graph, we looked at the patients by quantiles of risk, and as their quantile increased, the risk of overall morbidity went from 5% to 15% up to 35%. We saw that the average, the calculation by NSQIP underestimated the observed outcomes from NSQIP data. Which is frustrating because when I talk to a patient, I don't want to underestimate the risk of a complication. I want them to have an accurate or potentially overestimated risk so they can use that to make their decision. We found ours was spot on with the estimates, with the observed outcomes. In addition, Surpass only requires 5 entry variables once you're in the actual Epic encounter, whereas the ACS risk calculator requires 24 variables entered manually on the web. And again, it took the limit of the 1,000 patients was because he literally had to enter them into the EHR when he was at the hospital. We have tried to do some implementation of Surpass at UCH. with mixed success. We started with a study of about 200 patients in 8 surgical clinics and in the preoperative pre-procedure services clinic as well. And then we provided a survey to the patients and the providers about use of the tool. We found that as the patient's risk increased, providers found SURPASS to be more useful, understandably. Patients liked SURPASS regardless of their risk. The low-risk patients liked SURPASS because they said, it shows me that I'm making the right decision, that this thyroidectomy is low risk, I'm not going to have complications. It reassured me. The high-risk patients found it useful because they said, well, now I understand what I'm getting into when I'm going in for an esophagectomy. This is a useful tool to help me understand that risk. We found that surgeons were good at predicting who was low risk. It's a small sample. It's only 8 surgeons here. We found those same surgeons were not good at predicting who was high risk. If the patient was high risk, the surgeons were surprised at how high they were or overestimated that they were even higher. So the surgeons who say we like SURPASS for high-risk patients aren't good at figuring out who those high-risk patients are. So unfortunately, it goes to show that the patients are right that they found this useful regardless of their risk, and we've encouraged surgeons to use it regardless of patient risk. One of the quotes that was salient was, for the surgeries I do, SURPASS is really helpful just because it's a big, long, and complicated surgery, and it helps patients see that visually. Whereas patients said, when I came here, I was a lot more worried, but now seeing my risk percentages and how low they are, I have faith that surgery is going to work. So it's reassuring to the patients. The same study where we looked at, we found that 93% of the patients rated SURPASS as being very helpful or helpful. 99% said they understood their risks very or quite well. 83% of the time, the surgeons said SURPASS was very helpful, or somewhat helpful. 45% of the time, so just under half the time, the surgeon said that SURPASS changed their patient interaction. But that change was beneficial almost 100% of the time, 94% of the time. So right on, we're making progress. One of the surgeons said, I think it's been helpful for patients to see the numbers. They're more educated about their operation. It hasn't actually changed what I do in terms of surgery. Both patients and surgeons found SURPASS to be helpful for risk communication. Patients were more likely to desire increased engagement with surgeons when their calculated risk was high. As the calculated risk increased, surgeons found SURPASS to be more helpful, but again, we found surgeons weren't really good at predicting the risk. One of the surgeons said, SURPASS also can help with us in decision-making. For some patients that are really sick, we can choose a second line of treatment, which may not be quite as good, but if they're that sick, we picked it up from the SURPASS tool. So thanks to the surgeons and to our pre-procedure services clinic for engaging in this study. We then did a study where we took 10 surgeons who were naive to use of SURPASS. We had them do their usual consent for 10 consecutive patients, and then we taught them how to use SURPASS, which takes about 3 minutes to learn how to use it. It takes about 30 seconds to use. And then we had those same 10 patients administer SURPASS to their next, same 10 providers administer SURPASS to their next 10 patients. And we served the patients on the consent process after the interactions. 99% of the SURPASS patients reported the risk discussion was enough time, in their mind, enough time, versus less than that, 72% of the routine care. When we asked the patients to estimate how much time SURPASS took, or their consent and risk discussion took, the SURPASS patients estimated to be about half the time that the patients who had the standard method took. And again, this echoes my experience of when I now talk about my risk with patients, it literally takes me 3 minutes. They have 1 or 2 questions, and then we're done, as opposed to before it would sort of mumble through 5 minutes or more. 83% of the SURPASS patients were very satisfied with the risk discussion versus only 16% of the usual care patients. 78% of the SURPASS patients were made more comfortable with surgery versus only 19% of the usual care patients. And patient anxiety was greatly or somewhat decreased 92% of the time with the use of SURPASS versus only 20% of the patients receiving usual care. What struck me about this was usual care, usual risk assessment, so discussion of surgical risk with the patient in the usual manner, actually increased patient anxiety about surgery. Again, we're only looking at 100 patients from 10 different surgeons, but that to me was shocking to know that the discussion of risk actually made patients more anxious. And then pleasantly surprised to find that use of a risk tool to convey that risk actually decreased that anxiety. As of the last data pull I had from our EHR team looking at the frequency of use of Surpass, showed that pre-procedure services was knocking the ball out of the stadium with high use, and then there were myself and a bunch of providers using it. We even have a provider down at Memorial as of March who's using it with his patients. We've used it across all 9 specialties, mainly through the pre-procedure services clinic, where patients of different specialties have been getting Surpass, so that's exciting for me to see. Unfortunately, my understanding is it's not being used widely in pre-procedure services clinic anymore, but hopefully that'll change. So we have some upcoming implementation studies that we're trying to roll out to figure out how to better uptake use of Surpass. We have a study that one of our residents is doing on teaching the residents how to use it and seeing if that ground-up approach will take on instead of the faculty using it. We have a grant we're writing right now for multi-institutional implementation of Surpass in my thoracic surgery colleagues around the country. And then we're testing Surpass in non-trauma emergency patients at UCH retrospectively and hopefully prospectively to see if that guides their decision-making as well. We're trying to add additional features. We've developed a prediction of discharge destination. Our interviews with patients and patient focus groups revealed that what they really want is quality of life. When can I get back to good quality of life? When's my pain gone? When am I getting back to work? When am I spending time with my family? Am I going home or do I have to go to a skilled nursing facility? And quality of life. That's a really tough one to measure because the databases that we have don't have that. Does MPOG have quality of life outcomes? No. So, and that would be the golden egg, would be to find what the patients really want as opposed to what we think is important as providers. We've been working on combining patient-reported outcomes so that the patients are filling out input into Surpass and their outcomes so we can help track those. We are using Surpass to compare risks of different procedures side to side. So you see a provider and they want to present you with the option of open versus minimally invasive for one reason or the other. So that they can do a side-by-side comparison. Concurrently, we've had some grants and some research by our team with a collaborator named Katie Colburn, who used to be in the School of Public Health, but just recently joined us in the Department of Surgery a few weeks ago, where we've been able to engage in accurate identification of adverse outcomes from administrative data sets instead of relying on labor-intensive, expensive data sets like NSQIP or STS, where we've been able to identify overall complications, surgical site infections, UTI, bleeding, transfusion. So we're trying to prospectively validate Surpass on a large volume of local data, not just including our hospital. We've been using Surpass to try and improve quality in the Department of Surgery, use in M&M, morbidity and mortality conferences to figure out who was a low risk of having an adverse outcome but still did, and then guide subsequent data analysis. And then using it to identify processes of care to decrease post-op complications, such as best practice recommendations based on individual patient risks as opposed to global things, as well as to potentially guide IRIS implementation as well. And then finally, teaching accurate surgical risk assessment to trainees and trying to understand patients' and providers' differences in risk in risk perception. With that, so the summary of objectives: understand the current state of surgical risk assessment. So we know there's tools, they're inconsistently used. There's a poor understanding of patient risk by providers given the widely non-used tools. Understanding what patients desire from their providers during the consent process, improved communication, more clear information, transfer of information that's retained. And then understanding local options. We have this tool, Surpass and Epic. I encourage you to try it out. It should, again, be in everyone's EHR. I'm happy to troubleshoot it if people are having difficulty getting to it or using it. But I encourage you to try it out. I've been really lucky to have a large group of collaborators over the past 7 years, so I'm grateful to their help and their support. And I want to thank you for your time and welcome any questions.
I do think that our clinic plays an important role in assessing risk.
Yes.
But as you
Agreed. Agreed.
What are you doing to get that number of 8 surgeons?
Right. Right, and so that's the other challenge we've really been struggling with. I totally agree with you, Angie. The decision to have the operation is something that should happen in my clinic with the patient and me, not the patient conceding to surgery, and then a week later, people who don't do that operation are in a position where they have to convey that risk, and the patient may have questions or may be changing their mind. I agree with you. To me, that's an inappropriate way to go about decision making. We've tried to make a tool that's acceptable to the patients and providers and easy to use and put it in front of providers with mixed uptake, much to my frustration. And surgeons say, well, I'm just too busy in clinic. And my thoughts are, this saves me time in clinic. It saves me phone calls and emails and questions and post hoc changes. So why wouldn't we use it? And that's something that we all know how difficult medical dogma is to overcome, and we all know that surgeons are pains in the asses, and hurting surgeons is like hurting cats, and I can say that because I'm a surgeon. But I don't have the answer for that, and that's where we've actually had uptake and interest by different groups around the country, different groups within the UC Health system, more so than we've had by our surgeons here, to my frustration. I wish I had an answer, because then a lot of the pain and suffering I'm going through with trying to get this taken up, or any other tool taken up, would be alleviated. I welcome suggestions, though, too.
And then just from a practical standpoint, as someone who's used the SEPT tool,
yes.
I think one of the big barriers to use is making it really easy to use is the CPT code issue. The fact that we don't schedule surgeries here by CPT codes.
Right.
What we have is in our clinic nurse practitioners who don't necessarily understand the surgery, trying to compare it to listed surgeries within there. It's the same with the ACS.
Yeah. Yeah.
Is there any interest in the hospital in transitioning over to a system using CPT codes?
So we were surprised to learn that CPT codes aren't used for booking cases. They're used for insurance authorization. So my schedulers use the CPT code to get insurance authorization. Then they use a generic homegrown tool or term here, because that ties into the case carts that are pulled for the operation. So we don't know how to overcome that obstacle. We've talked to administrators, and they're unaware of largely what goes on in the ORs in that respect, because that's pretty much a homegrown thing. We actually have, and I agree with you, entering the search term can be frustrating unless it's a really common term. But you pull up esophagectomy and there's 7 different options, and so am I doing a transhiatal and Ivor Lewis, I'm doing minimally invasive, I'm doing colonic and imposition. So there is that is one of the limitations with the SURPASS tool. One of our residents has taken on the task of hand identifying colloquial terms for each of the surgical procedures in that 3,000 procedure list. I check in on him every few months, and he promises he's making progress. I haven't seen anything, so he might be waiting to do it the night before it's due. But so that's one of the frustrations we have too. And we actually talked to the software development company. There's a company called Agile MD, which UC Health hired to do all their clinical decision support. So they started in the ER with clinical pathways. They then did the outpatient infusion center for chemotherapy for stuff. Then they took on our project, and we were really grateful for Rich Zane giving us the resources to do that. We've talked to them about getting a better search engine, and they don't have a good answer, because they don't want to pay for it, and we're trying to figure out how to overcome it at numerous levels. So that's another sticking point that we wish we could overcome more easily. Yeah, absolutely.
And I'll stop monopolizing the conversation, but you showed the data in terms of 30-day morbidity. Have you compared the other outcomes in SURPASS to the ACS control, and how does it compare?
So we didn't, because of the laborious nature of literally a resident entering 24 variables 1,006 times into an online database, and then or an online search engine, and then manually writing down the output. The study that we're about to undertake that looks at emergency patients, we've asked the resident to record all of the 11 outcomes, so we can actually have a more detailed evaluation. We have the same question. Yes, sir.
How many patients say no?
To surgery?
Yeah, after they
Yeah. Yeah. So I've had, by the time I'd used this 222 times in that slide from March, I had one patient say no. And that was a patient who was a wheelchair-bound gentleman who had advanced esophageal cancer, and we were doing an esophagectomy on, and I showed him his mortality was in the 20% range, and his morbidity was over 50, it was like 75%. And I said to him, we can do surgery technically, but maybe this isn't the right answer. And he and his wife looked at it in my clinic, and he said, I'm going to think about it. And then he called back and he said, I'm going to go with chemotherapy and radiation. I think that's absolutely appropriate. I mean, this to me is where the tool really guides that decision making. So to me, that's a bonus, not detrimental. I do one less esophagectomy, but more importantly, we've steered someone towards their desired outcome. So anecdotally, I've had one patient say no out of 220.
So the risk, the number of patients is so low to say no.
Yeah.
Then is it really risk? Are we really doing what the whole point is? In other words,
yeah.
Why do it if 99.9% of patients say let's go with anything?
So I don't use this tool. I don't see this tool as a way to dissuade patients from surgery. I see this tool as a way to make patients more informed about their surgical decision making. So from my perspective, and when we look at the data, the majority of patients are ASA 1 or 2, not 3, 4, or 5. And so this tool is educating them on their risks. And when you look at it, when we've asked, we're actually in the process of doing a study. We have some preliminary results back. When we ask surgeons, what's the patient's risk of mortality and morbidity, surgeons are all over the place and usually overestimate it when you actually have them put a number down. Whereas most of the patients that we see have surgery, the outpatients, their mortality estimates are less than 1%, and their morbidity, overall morbidity, is usually on the 2 to 3% range, maybe 4%. So if a patient says, look, I'm having an inguinal hernia, I'm really low risk, and they agree to surgery, they're informed. To me, that's much more informed. If they're higher risk and they're thinking about, okay, do I undergo surgery for cancer or do I undergo chemotherapy and radiation in exchange, knowing what the pros and cons of those are, and they opt for one or the other, to me, that's a much more clean decision that they've made because they've been informed. So I don't see this as a tool where we should be getting a 50% of patients who see this tool say no surgery. I see this as a tool to say patients are more satisfied with their decision and more comfortable with their decision because they feel more informed about their decision and therefore can make that decision on their own. That's my take on it, Bill.
Thank you for your talk about using data. I think it's super applicable. In the children's world, we have a hard time figuring out if the surgeons really know the difference between ASA 2 and 3.
Yeah.
My question is, if you compare the 2/3 of use in pre-op clinic,
Yeah.
who are more kind of familiar with the real applications of ASA
Yeah.
status, and then you compare it to the surgical population, filling that data out, is there inter-rater reliability? Do you have patients that got rated by both?
We haven't done that. That's a great idea. On the tool, what I didn't show, I didn't pull up the live tool because you have to go through Epic to get it. But if you hover over the ASA, it actually puts the one-line description that's standardly used for ASA. And so we're hoping that educates the provider. We don't always agree. The agreement's around 50%. Someone said, well, you're a thoracic surgeon, so all your patients are 3. So, well, I'm taking care of a 22-year-old with pectus excavatum who's totally healthy otherwise. So I had hazard he's an ASA of 2 because he's got a physiologic derangement from his pectus excavatum, but otherwise no systemic diseases. But that's a really good point. We have not done that. And the data is available in ACS NSQIP, pediatric NSQIP, to do the same type of assessment. I'm not a pediatric surgeon. I don't live in that world, so we haven't pursued that. But if anyone's interested, we've got the resources. It shouldn't be too hard to move forward with something like that. Brendan.
Rob, thanks so much. That was a great talk. Have you tried, or is there anybody using this in lung transplant?
We don't have data on lung transplants in NSQIP. So NSQIP doesn't collect cardiac surgery, abdominal transplantation, lung transplantation as well. So I don't have that data. The STS data set does collect that data for cardiac surgery and for lung transplantation, but it's a black box. We can't get the actual data to do the analysis ourselves. We have to pay the Duke Clinical Research Institute to do the analysis, so we haven't pursued that. But that would be great. I mean, I'd love to see this in a more useful tool, a more useful tool like this for the cardiac surgery patients who are higher risk, as opposed to the STS risk calculator, which I showed you.
Back to your point about how people come at this from different angles, like we have the experience of seeing the bad outcomes in the ICU.
Yeah.
Hearing sometimes what our perspective is, and then the vast difference of, say, like what their thought process is. And sometimes, this patient's never going to survive. They're never going to, well, that's not necessarily true.
Yeah.
What we found is that, when we're asked about percentages or not just survivability, but quality of life after discharge from the ICU, there's a huge excitement in that area of research with such little data of how many people can return to their lives, how many people don't suffer from PTSD, how many people. And it's tough to, without data, to give them any kind of reason.
I agree, and that to me is another frontier of medicine, is collecting long-term outcomes on quality of life and things, again, that are meaningful to patients as opposed to the metrics we use for hospital quality metrics and U.S. News and World Report. What is really meaningful to the patient? What is it that they want? What data do we need to get to achieve that? Unfortunately, you need a massive database with a long-term outcome, and it would be really tough to collect these qualitative data points. I perceive it as tough, but to me, that's really something that we need to focus on as a discipline, and that's probably a long way off, unfortunately. All right, thank you, everyone. Thanks for your time, and again, I'm happy to discuss this at any point too.